So how much time we have, Dr. Dipen? Half an hour or
We can
less?
have 20, we have 20 minutes to 25 minutes.
Okay, fine. So we'll start with the first OSCE, and as far as I understand, the participants would answer in the chat box.
Yes, yes.
So it's not moving.
You
Can
click
you
on
see?
the screen and just try to do page down.
Yeah.
Yes.
Okay.
Yeah.
Yes. Thank you. So let me open the chat box. I have to see the answers, right? Yeah. Okay. So this is the first one where we have a primary gravida delivered a male newborn at term gestation by normal vaginal delivery. On day 5 of life, mother develops fever and vesicular rash all over the body. So what is the likely diagnosis? Okay, good. We have got varicella already answered by many people. So the next question would be, how can we prevent the same infection in baby? We are currently talking about varicella in mother, not in the baby. Okay, somebody mentioned isolation. Anything else? Somebody said varicella zoster, immunoglobulin, LSCS. Baby is already born by normal delivery, so we can't go back and do CS. Isolation, IVAG, immunoglobulin, okay. Fine. Good. So let me see the next. Let me go back to the next slide. Okay. So yes, all of you are right that it is a varicella infection in the mother, and because mother has developed this rash on day 5 of life, so baby is still at risk of developing neonatal varicella, and best would be to separate mother and baby until maternal lesions have dried up and crusted, but we should be giving expressed breast milk to the baby. If at all baby develops rash, then we should ideally treat with acyclovir. In this baby, I mean, there is not much of need of giving immunoglobulins, because it is usually when mother has a rash either 5 days before delivery or within first 48 hours of delivery, then it is probably indicated. But again, these decisions are based, different units have different protocols. But yes, definitely we need to separate baby and mother so that baby does not get an infection from the mother. Okay. So we'll move on to the next. Right. So I hope the picture is clear. So this is a healthy term baby and has something on the lip. Can you tell what it is? Is it I hope it's clear to everyone, that it's visible properly.
Yes, it is visible.
Okay, sucking blister. Two people have answered sucking blister. One person is saying herpes, mucocele, mucocele. Okay, fine. Let me give you another question. So it's a sucking blister actually. Now, what is the treatment for sucking blister? Wait and watch. Okay. Nothing. Reassurance? No treatment, nothing. Okay, fine. So we'll move on to the next slide. All of you are very intelligent. So it is a sucking blister, and as you rightly said, no treatment is required, only reassurance is to be given to the mother. Okay. Now let's do this one, third OSCE. So you have a 2-day-old term baby who is presented with severe respiratory distress and is being ventilated. Emergency CS was done for non-reactive CTG, and there is a history of meconium stain liquor. On examination, baby's heart rate is 150 per minute, capillary refill time of 3 seconds, mean blood pressure of 48 millimeter of mercury. Ventilation wise, this baby is on pressure control volume guarantee with set tidal volume of 4 ml per kg. Maximum PIP is set at 24, P is 7, FiO2 of 0.75. So 75% and a respiratory rate of 40 per minute, and this is the ABG. pH of 7.16, PCO2 of 57, PO2 of 44, bicarb of 19, base excess of minus 10.4. So can you please interpret this ABG? So somebody said primary respiratory acidosis combined metabolic with hypoxemia, then respiratory mixed. Mixed acidosis with hypoxemia. Okay, good. So it is a mixed acidosis with hypoxemia because you have, so how do you interpret any ABG? So first you would look at the pH. Your pH is 7.16, which is acidotic. The next step would be to look at the carbon dioxide, which is 57. So it is little bit on the higher side, being ABG. And then you would look at your bicarb. So normally with the rise in the CO2, you would expect the bicarb also to increase, but here the bicarb is 19 and base excess is minus 10.4. So yes, it is a mixed acidosis, and you have a PO2 of 44. So there is an element of hypoxemia. So you all are right. It's a mixed acidosis with hypoxemia. Next question. So could you throw some lights on provisional diagnosis in this baby? What do you think is the possible diagnosis with this baby who is 2 days old? MAS with PPHN, right? Meconium aspiration syndrome, meconium aspiration, PPHN. Okay, great. It's very clear, right? From the history, from examination, as well as ventilatory settings and blood gas. Although what should we, there are a few things we need to do to confirm the diagnosis in terms of the X-ray, echo, etc. But yes, provisionally we can say this baby is having meconium aspiration syndrome with PPHN, possibly. Okay, so let me go back to, so yes, your answers are correct. Mixed respiratory metabolic acidosis with hypoxemia and meconium aspiration with PPHN. Next one. So this is a term baby who is noted to have a progressive respiratory distress immediately after birth. And this is the X-ray. So can you, from the X-ray, what do you think is going on with the baby? What is the diagnosis? pneumothorax, tension pneumothorax. What? CPAP? CPAP? Left pneumothorax with mediastinal shift. Okay. So on what basis you all are saying pneumothorax? Somebody has written CPAM. Can you write a full form, please? CLE. What is CLE? Full form? Congenital pulmonary airway malformation. Airway malformation? Congenital lobar emphysema. Thanks a lot for. Okay, fine. Lobar emphysema. Congenital pulmonary alveolar malformation. Anybody else want to answer any more now? Okay. So let's look at the next question and then we'll discuss. Investigation of choice. Whatever is your diagnosis, what would you do to investigate? Congenital pulmonary adenomatous malformation. Okay, somebody said CT scan. Focus. Okay. CCT. Okay, let's look at the next question after this. CT scan. Definitive treatment. Based on your diagnosis, obviously, but ICD, those who think it's a pneumothorax. Somebody said surgery, ICD. So those who think it's a pneumothorax would like to put ICD. Those who think it's a congenital lobar emphysema would like to do surgery. Okay, fine. So obviously, once you do CT scan, it would confirm. But this baby has left-sided congenital lobar emphysema, and your investigation of choice would be CT scan, and the definitive treatment would be lobectomy or surgery. Okay, I mean, here, yes, you definitely want to rule out pneumothorax in this baby. So you can do that by various things. You can do the lung ultrasound. CT scan obviously would give you the difference. But here, this is a term baby who is born. There is no history of positive pressure ventilation given, and there is a progressive respiratory distress immediately after birth. And you can see the entire, the entire lobe of the lung being overinflated. So that is something which is going against the pneumothorax, but surely you have to look at various things and then take a wise decision. So we'll move on to the next question. So this is a neonate who is brought to emergency department at 28 days of age with history of poor feeding and lethargy. And on examination, the capillary fill time is prolonged. There is a feeble peripheral pulses, and ECG is like this. So what is your diagnosis looking at the ECG? SVT, PSVT. SVT. Right. Okay. And name the drug of choice for the treatment. Adenosine, correct. Okay. Fine. So it is basically a narrow complex supraventricular tachycardia, because you can't see the P waves and Your heart rate is almost very fast. It's around 300, right? And the drug of choice is adenosine. So, can anyone tell me the dose of adenosine? How much adenosine would you like to give? 0.1 mg per kg, correct. And how will you give it? So, is there any specific, you need to follow certain thing, rapid, correct, with flush, okay. How much flush you would give? Two-way flush, correct. Very good. Yeah, so you can use the, um, ideally it should be given, if you have a central access, that would be great. If you don't have, then you can give through the peripheral cannula also, but you need to be ready with the adenosine as well as the 5 ml normal saline flush, and you can use the two-way, you can use the three-way valves, and immediately after pushing the adenosine, you need to be really fast in pushing your flush. Okay. Left antecubital vein, correct. Yeah, as close to the heart as possible. Okay, fine. We'll move on to the next. Okay. Right. So says something about nutrition. Now, there are some important electrolytes and minerals in the breast milk, like calcium, phosphorus, iron, sodium, and potassium. You need to match the mineral or electrolyte with its breast milk content in the units of milligram per liter. Okay. So, like, what you can do, you can write the answer in the form of what would be the answer for A, what would be the answer for B, C, D, like that. So, you may need some time, think about it carefully, and then write. You still thinking? I hope nobody is using mobile phones and Googling up. I'll give you 10-15 seconds more. Or if you don't know all the answers, what you can do, you can write certain things, like those who know some values can answer. If you know how much is iron in the breast milk, you can answer that. Looks like nobody wants to attempt this question. So we need to, okay, somebody give the wait. A2, B1. Okay, A2. So A is calcium, number 2 is 250 to 350. Sounds good. B1, B is phosphorus. Okay. Iron is E, correct? Okay. A6. A6, okay. A2. E6? What is A6? A2, B1, C6. C6 makes sense, okay. D3, D is sodium, 100 to 160. Nobody wants to answer anything for potassium? Potassium? Who wants to give answer for potassium? Because that's the only one which is left, I think. Doctor, who is this doctor? Okay, one more new answer come up. Ashwini saying A2, C6. C6 is right. A2, Calcium is also right. Nobody wants to attempt for potassium. Whichever is left is potassium. E3. 3. Okay. Okay. Fine. I'll give you the answers now. So it's a tricky one. A2 is correct. So your calcium is roughly. So see, these values are not the absolute values. So you can't mug it up really. But based on various studies, they have found rough estimates. Okay. Because again, you know that breast milk composition changes as per the, the day of life, the gestational age of the baby, and all those things. So values may not be like an exact value, but still the best match is this. So for calcium, answer 252, 350 milligram per liter. Okay. For phosphorus, it is 100 to 160 milligram per liter. For iron, 0.3 to 0.9 is correct milligram per liter. For sodium, 120 to 150 milligram per liter is correct. And for potassium, it is 400 to 500 milligram per liter. Okay, so that's the correct answer. Now we'll move on to the next one. Okay. How much time we have? Another 10 minutes. So identify this condition. CTEV. Please write full form if you can. Clubfoot CTEV. Bilateral CTEV. Please write full forms. Those who are writing CTEV, please write full forms. Does this look like a... Yes, okay. Somebody's written rocker bottom. Who's written rocker bottom? It's moving very fast. Rocker bottom, Pamela. Okay. Dr. Mary. She wrote first, okay. Right. Okay, fine. So there is more voting goes to congenital telepathic equinovarus. Rocker. What is rocker? Okay, fine. I will ask next question and then I'll show you the answers. So, right. So, okay, let me tell you, this is rocker bottom feet, okay? This is not congenital talipes equinovarus. Those who are saying congenital talipes equinovarus, please look at the pictures and please read about it because this is not varus, this is almost valgus, like the both feet are going outside, turned outside. Whereas in CTEV, they are usually congenital talipes equinovarus. Varus means they are turned inside, not outside. So it is definitely not CTEV. It is rocker bottom feet. And now you tell me the answer. What is the underlying anatomical problem? Vertical talus. Okay, good. Edward syndrome. Okay, fine. It's that is next question, but that's fine. But what is the underlying anatomical problem? If you know your anatomy, then only you can answer this. You need to know how many bones are there in 1 foot and what are the various names of those, like, talar bones and metatarsal, tarsal. Okay, we'll move on now because it's bit taking too much time. Okay. Name 2 most common disorders associated with this condition, rocker bottom feet. Oh, sorry. I already clicked the answer. Edward Pata. Okay, fine. Let me. Fine, sorry. So this is rocker bottom feet, congenital vertical talus. Somebody mentioned that vertical talus. So here the problem is that your, there is a talonavicular joint. The joint between the talus and navicular bone is dislocated, and it is sort of a bony problem. So it is irreducible, rigid, irreducible dislocation of talonavicular joint. And there are, does anybody know how many bones are there? How many kind of, bones are there in 1 foot? So interesting. It's not, I've not asked this question, but it was very, it's something which you need to really go back and look at the anatomy. So there are 26 bone in 1 foot, and out of which there are 5 talar bones, and talus and navicular bones, there's a joint between that bone, and that joint is actually dislocated. So then that gives rise to this deformity, and Edward and Patau are your most common underlying conditions, but it is also present in certain neuromuscular conditions like your spina bifida or myelomylingocy. Okay, so we'll move on to the next question. Right, okay. Abnormal. So an abnormal apical four-chamber view of heart showing atrioventricular valves is seen with many but not all forms of congenital heart disease. Which of the following cardiac diagnosis could have normal four-chamber view? TGA, already somebody answered. Anybody else want to say anything about it? TAG? TGA. 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 Okay, fine. Perfect. Everybody knows the answer. Transposition of great arteries is the answer. We'll move on to the next question. Okay, so this is an X-ray. This is an X-ray. Tell me what is abnormal in this X-ray. Lines in heart. Okay. Lines. High UVC and UAC. Okay. What level? Which one is UVC and which one is UAC? Can somebody cardiomegaly? Loop is UVC. Okay. And at what level UAC is? Curved one is UAC. Okay. And UAC at T2. Good. Very good. So you all are good at your lines. Okay. Fine. I would move on. So you all are right that UAC, the looped one is UVC, and the one which is straight is UAC, and the UAC is at T2, and UVC is in heart. Okay. Now, next question is, what is the appropriate vertebral level of high and low positioned umbilical arterial line? So somebody's written T6 to T9, L3, L4. Okay, fine. UAC T4, T6. T4, T6 is a bit too high. T6 to T9 high. Okay. At level of diaphragm, T6, T9. At level of diaphragm should be UVC, not UAC. T6, T9. Okay, fine. Okay. Sorry. Okay, so you have identified, right? High placement of umbilical lines with UVC looping inside the heart, UAC inserted very high at T2, and high umbilical arterial line. So high level is T6 to T10. Some books say T6 to T9. And low umbilical arterial line is at the level of L3 to L4. Okay. Why it is important to maintain the maintain correct position of umbilical arterial line. What is wrong if you say, for example, your umbilical arterial line is at T12, branches of aorta, thrombus, sepsis, dislodgement. Okay, good. If it is at T12, what would be the risk? Which organ will get affected? Renal vessels. Okay. Liver, intestine. Very good. Correct. So basically, you need to understand the anatomy, where at what level aorta branches and gives rise to various arteries, and based on that, these are the correct levels identified. I mean, the celiac vessel, and the main worry is your mesenteric circulation. Yeah. So you don't want your mesenteric circulation to compromise, and that is why we prefer it to be either T6 to T9 or low lying at between L3 to L4. Okay, fine. We'll move on to the next. I have total made 13, but whenever we want to stop, please let me know and I will stop. OSCE 10. So investigation of Acha. This is an investigation MCUG. Okay, fine. 2 days old male child. What is the investigation? MCUG, right? Okay, MCUG. Perfect. Okay, what is next question? What do you think is going on here? What is the diagnosis? VUR, okay. Vesico-ureteric reflux, grade 5, okay. VUR, grade 4. Is it unilateral, bilateral? Posterior, PVB? Bilateral, okay, fine. So, it's a male newborn. So, what could be the cause for this in a male newborn with only 2 days? Posterior travel, perfect, okay. Fine, move on to the next question. This is cranial sonography image. Can you tell me which view is this? Corona. Okay, fifth view. What is fifth view? I don't know. Coronal is right. And what do you see? The arrow. What is it? What can you see the arrow? What is that? Cyst. Good. Choroid plexus cyst. Okay, fine. So it is a choroid plexus cyst on one side, seen in the coronal view. Fine. Okay. We'll move on to the next. Okay, some developmental questions. So mention the age of achievement. So give me range, okay, of the following milestones. You don't have to give one number, just give the range. Would be better because we can't give running. Every child is different, so there should be a range. 15 to 18 months, 18 months, around 18 months, 15 to 18, 18 months, 18 months, okay. 18 months to 2 years. Good. Fine. Okay, next one. 18 months to 2 years is the correct answer. Copy a circle. 3. Okay, fine. This is MBBS question, isn't it? Able to speak 1 or 2 meaningful words. 1 year. 1 year, 1 year, 1 year. 3. What is 3? 12 months, 1 year. Okay, fine. Okay. So, okay, you all are right. You all have read your development. So running between 18 to 24 months, copy a circle at 34 to 36 months, able to speak 1 to 2 meaningful words between 12 to 14 months. Now just remember, in development, it is always a range because every child is different. And the second thing is we need to understand the red flag signs. So obviously normal development is important, but at the same time, we need to know that what is the highest age by which if a child is not able to achieve certain milestone, then we need to take some actions. I'm sure you all are aware of that. Okay, we'll move on to next. This is the last one, I think. Okay, so look at this. This is obviously a karyotype. Okay, what do you see here? What's abnormal? Trisomy 13. Very good. Pata. Perfect. We are done. Okay, fine. Everybody, it's very obvious. You can see 3 chromosomes at chromosome number 13. So this is trisomy 13 Patau syndrome. Can anybody tell me the features of this condition, if you remember? Oh, I didn't ask next question. Okay, fine. I've already given you answer. What is the cause of this condition? It's a non-disjunction in the maternal meiosis 1 in 90% of cases. Okay. Now, just for 2 minutes, if you can tell me what are the various clinical features you see. What happens in Patau? Locobotum, polydactyly, hypotonia, cleft lip, good. Cleft palate, okay, fine, good. I think we are done with our session. I only have 13 MCQs and 13 OSCE for you. Thank you very much. It was very good. All of you are very intelligent and you could answer majority of questions. Good. Okay. Thank you, Dr. Dipen. I'm done with OSCE.
Yeah, you can now stop sharing. Yeah, thank you, Dr. Resma. It was really an excellent session of OSCE. And I thank Dr. Rahul Verma sir also for being an expert. There is one announcement. Next week we do not have FEAT session, but we will have an expert lecture from Dr. Somashekhar Nimbalkar. He will be discussing on literature search, how to search for the literature when you are interested to do for your research or thesis. So it will be a very interactive session. So I request everyone to be present next week, 8 to 10. So meanwhile, good night, everyone. Thank you so much. So we are closing the session now.
Thank you. Good night. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you, Saitanam. Thank you.